Good morning or good afternoon to whoever is on the East Coast or Central CST. Thank you for joining me today. My name is Dr. Ndidiamaka Okpareke. I go by Didi. I'm the president and the owner of Olive Tree Compounding Pharmacy. And today I would like to welcome you to my Fireside Chat, which is geared to discuss how HRT is a supercharger for weight loss. So this is going to be very interesting. To begin, I would like to open up the chat and ask you to please comment, where are you? Where are you tuning in from? Where are your friends and your family? The reason why I ask that is because anytime we receive information, we should really be a vessel, and a vessel allows information to pass through. And so whatever you learn today, my goal is for you to be inspired enough to share with your friends and your family, no matter where they are. From the East Coast to the West Coast, internationally, please transfer this information to them because you never know how it's going to impact the people around you and your community members. If you are a provider joining us today, please let us know, where are your clients or your patients? Who do you serve? Who calls you for information? Who relies on you to help them with their health, to balance their weight and to balance their hormones? This information is also for them. And at the end of our chat, you will see how this question is highly relevant because I would like to partner with you. So let's begin. Today's objectives, we would like to review the hormonal changes of life in both men and women. We are also going to identify the health implications of obesity. We will highlight the essence of estradiol in weight management, and then we're going to discover the connection between estradiol and GLP-1 agonists, which is the coolest thing that I've discovered as I've uncovered and unraveled and researched a lot of this information. So to review what we talked about in our first fireside chat, we looked at the different hormonal stages of life in both men and women. So in women, after adolescence and after our 20s and into our 30s, we get into this phase that's called perimenopause. So perimenopause is super exciting, but then it's also challenging. It's challenging because this is typically when we start to notice an imbalance in our hormones. Most of the time, perimenopause comes along with estrogen dominance, meaning that we tend to have a lower production of progesterone during perimenopause. And if estrogen is dominant during perimenopause, this is when we notice that it's so much harder to have a management on our weight. After perimenopause, we are led into menopause. Now, menopause is just a natural part of life. It's a significant milestone in a woman's life, and it typically occurs between the ages of 45 to 55. Sometimes it can happen earlier in life, and sometimes it can happen later in life. It can also be induced. It can be induced by hysterectomies, where the uterus and the ovaries are removed. But what research is showing is that menopause is also influenced by environmental factors, chemical factors, the way that we eat, our sleep routine, so on and so forth. After menopause, we as women go into this phase called postmenopause. Now, postmenopause is the 12 months after a woman ceases to have menses. And so basically, this is defined by that period of time where the ovaries stop producing estradiol. And then in men, we have this phase of life that's called andropause. Now, it's very interesting because if you ask men who are maybe around the age of 35, 40, what's been going on? How have you been feeling? They will tell you, oh, no, I'm just getting old, but what they don't know is that there is actually a phase of life called andropause. And this is basically the male menopause, where the production of testosterone, which is the main hormone in men, it starts to decline. And it's a very natural thing, but it's unnatural to stay that way. It's very important to seek the guidance and the help of practitioners such as pharmacists, nurse practitioners, medical doctors in order to address andropause, because it's important to have testosterone for longevity, for cardiovascular health, it's neuroprotective, and so on and so forth. So let's review hormones. These are some of the hormones in the body that are super important. At the top, I have estradiol, and that's only because that's what we will be discussing today. Vitamin D is also an extremely important hormone. A lot of people think vitamin is just a vitamin, but it's not. It does over 1,000 things in the body. If you look at any of the chemical pathways in the body, vitamin D somehow or some way plays a very important role. So does progesterone. Progesterone is a little bit higher up in the hormone cascade, but it's super important in men and in women. DHEA and testosterone, those are our androgenic hormones. Testosterone is super important because as we start to see a society that is becoming more and more reliant and dependent on GLP-1 therapy, such as semaglutide and tirzepatide, we start to see that testosterone is a very significant hormone in those patients. Why? Because those medications tend to cause a decrease in lean muscle mass. And so testosterone, which one of its very primary roles is to maintain muscle mass, is important in patients who are using those medications. Cortisol, this is just one of those hormones that can wreak havoc if you allow it to. As we get older, our HPA axis, there can be some disruption and dysfunction in that HPA axis. And cortisol is the hormone that is typically released when it's not supposed to be. At those high levels, it can cause you to gain a lot of weight and feel very uncomfortable. You can have insomnia, like I said, weight gain, you can have cravings for sugar. And so maintaining a healthy cortisol level is very important. Thyroid, free T4 and free T3, along with the TSH. Those are hormones that work in that thyroid system. But basically, thyroid is super important for metabolism and so on and so forth. But like I said, for today, we will be focusing on estradiol. Obesity. When we look at obesity, we know that obesity has so many so many effects on our metabolism and our metabolic health. The negative effects of obesity are insulin resistance, type 2 diabetes, cardiovascular disease, dyslipidemia. But then I highlighted this one, an altered HPO axis. HPO stands for hypothalamus, pituitary gland, and ovaries. These three organs work together in the body. But when we have an altered axis, we tend to see things like infertility, amenorrhea. We tend to see PCOS. We also have delayed puberty, signs of hypothyroidism. And so maintaining the regular function of our HPO axis is extremely important in women. Estradiol levels. Now, I broke this up into two significant categories. Either you have normal estradiol levels or you have abnormal estradiol levels. When your normal periovulatory levels of estrogen are present, they produce an anorexigenic effect. Now, this anorexigenic effect takes place in the hypothalamus, which is in the brain. There are neurons in the hypothalamus, and estrogen binds to those neurons. When estrogen binds to those neurons, what happens is you notice a decrease in food intake, a reduction in appetite. We also notice an increase in energy expenditure. So what that looks like is, let's say a woman is in perimenopause. Perimenopause, during the follicular phase, the beginning of the cycle, a woman has normal amounts of estrogen. She's out exercising, she's going on hikes, she's lifting weights, she's swimming, she's going out with her friends, her skin looks good, her hair looks amazing, her nails, everything is working the way that it should. On top of that, she doesn't notice any weight gain. She's able to maintain the weight that she desires. She doesn't notice any cravings, abnormal cravings, especially for sugar, carbs, and starches. And then she sleeps really, really well. So that's what it looks like when we have this anorexigenic effect from normal estrogen levels that bind to the hypothalamus in the brain. It also produces a neuroprotective effect. And so this neuroprotective effect, what it does is it increases energy production in the neuronal mitochondria. It also enhances cell survival pathways, and it reduces oxidative damage. The reason why I highlighted this is because I believe this is where research is going, and it's very, very important. So just remember, estrogen in the brain reduces the amount of food that we eat, it reduces our appetite, it increases our energy, and then it also protects our brain. Now, the opposite of that, category 2, is abnormal levels of estrogen, the orexigenic effect. And so when we don't have estrogen in the brain, it can lead to the opposite of all of these things, including weight gain. When do we tend to see abnormal levels of estrogen? Well, this can happen during adolescence. It can happen in perimenopausal phase, menopausal, postmenopausal. But basically, not enough estrogen leads to weight gain because you don't have that anorexigenic effect in the brain. Now, in pregnancy of PCOS, it's the opposite. It's not that they don't have enough estrogen, it's that they have way too much estrogen. And so in pregnancy, when a woman has way too much estrogen on board, this is what is linked to gestational diabetes and obesity during pregnancy. In PCOS, PCOS is a condition, polycystic ovarian syndrome is a condition where too much androgen is being produced by the body, too much testosterone. Now, what a lot of our clients don't know is that testosterone can easily be converted to estrogen. And so usually when you have a PCOS client, you notice that they have a lot of estrogen, not necessarily because their ovaries are overproducing estrogen. It's that the testosterone that is produced by their ovaries is converting to estrogen. Now, if we look at GLP-1, GLP-1 stands for glucagon-like peptide 1. GLP-1 is produced naturally by the body, okay? It is also the target of the medications that are on the market now, semaglutide and tirzepatide, and so many others, but those two specifically. So it's produced naturally by the body, both peripherally and then centrally in the brain. Peripherally, it's produced by the pancreas and the intestinal L cells whenever we eat any type of sugar, starch, carbohydrates. It triggers the body to naturally produce GLP-1. It's also produced in the brain in the hypothalamus, the hippocampus, the hindbrain, and the mesolimbic system. Now, this is critical because the hypothalamus is also the same place that estrogen works. And so I hope you're beginning to see that there is a connection between estrogen and GLP-1 analogs or GLP-1 agonists. They both work in the hypothalamus. Now, in animal studies, what was noticed is that whenever the GLP-1 receptor was suppressed, meaning it wasn't working, they noticed that these animals, mainly mice, had an increase in food intake. But when the receptor was not suppressed and the GLP-1 was administered or allowed to bind to the receptor, it produced the anorexic response, a reduction in food intake and also a reduction in meal size. So isn't it critical that this is kind of the same thing that estradiol does in the brain? When estradiol is able to work on the neurons in the hypothalamus, it produces this anorexigenic effect. So here we have it. This is the link between estradiol and GLP-1 agonists. In animal studies, both were able to bind and stimulate in the hypothalamus and the brainstem to control appetite and control weight. It produced a reduction in food intake and meal size, and it produced a decrease in weight. Now, remember when I said to remember this neuroprotective effect? This is why. It's because if we have insulin resistance in the brain, insulin resistance in the brain is linked to neurodegeneration. And that neurodegeneration is linked to Alzheimer's disease and Parkinson's disease. So it is very important to control insulin resistance in the brain. And the way that we do that is not only with estradiol, but with GLP-1 agonists. And so I think where research is going is figuring out how do we take these GLP-1 agonists such as semaglutide and tirzepatide and attach some type of estrogen analog, attach estradiol to it so that when it's administered, not only do we have PCOS management, lipid management, cardiovascular management, but then we also have this neuroprotective effect. So it'd be interesting to see where research takes us with these medications. But this is also important to highlight why HRT, hormone replacement therapy, in perimenopause, menopause, and postmenopause is very significant. It's not necessarily just about replacing hormones, but it's about the effect that it has in the body. Estradiol is extremely important for neural health, cardiovascular health, lipid health, and so on and so forth. So what do we do here at Olive Tree Compounding Pharmacy? When I started my pharmacy in 2017, one of the more central services that I wanted to offer to my community members, working with providers, working with patients and clients, was hormone consultation services. There aren't very many places that people can go to receive comprehensive care that addresses hormone balancing. And so that's really the central of what we do. And now when we've added semaglutide and tirzepatide as products and services to my company, we pair them with our hormone consultations and recommendations. So let's become partners. How do we do that? Well, if you're a provider and you write prescriptions, you can email them to us, you can fax them, or you can e-prescribe. And know that we also ship to patients who are not in our immediate vicinity. We ship via USPS and also via UPS. We are licensed in many states and growing. We have a license here in New Mexico, obviously. In Texas, we are licensed for non-sterile compounds, so we cannot send tirzepatide or semaglutide to Texas, but we can send hormone replacement therapy to Texas. Wisconsin and Maryland, we are also licensed in Indiana, Illinois, Nevada, and Georgia. What about comments? What do you guys think about this information?
I thought it was really interesting. I'll just go ahead and jump in.
Yeah.
Especially the neurodegeneration. So interesting. I didn't know that connection. And so I really appreciated having seen, I'm writing you an email right now, what's going on with one of my besties who never had any HRT. She's 70
Wow.
and and she's always been super spunky and active, and
Mhm.
her memory is starting to slip. Is
Yeah.
it too late to get her on?
No,
You
no,
know,
not at all. And in fact, whenever we see, whenever I see, any type of memory problems, I tend to think that that's more of an issue with higher up on the hormone cascade. So that's when I start looking at pregnenolone. So pregnenolone comes from cholesterol. Okay, by the way, if any provider ever tells you you should not have cholesterol in your diet. It's not about not having cholesterol. It's about balancing it. Why? Because hormones are produced in the body from cholesterol, right? So patients who are on statins, they really do have a problem with hormone balancing because statins cut out cholesterol production, right? And if you take statin medication and you also have cholesterol in your diet, it will prevent your body from being able to use the cholesterol. So whenever I have a patient who is suffering from memory loss or any type of, neuro type of process, the first hormone that I look at is pregnenolone. So it's not too late for her. If she's interested, we can certainly connect with her via phone. We can do a Zoom session. We can also send her one of our saliva test kits so that she can go through the process and we can kind of walk her through it to make sure that she gets the right therapy. Yeah.
well, thank you so much.
Yeah, definitely. What is the best time to introduce HRT to my patients who may be considering a GLP? It seems like that's a better place to start in some cases. Yeah. This is a very, very good question, because it's like the chicken versus the egg, right? Like which one comes first? There's really no first or second. I think it's all together. It's all together because when we start to notice that it's more difficult to manage our weight, that it probably is due to some type of hormonal imbalance as well. So really GLP-1 therapy plus hormone replacement therapy should be sought at the same time. So, like I said, if you know anyone who can benefit from speaking with me, I also have another pharmacist on board, Dr. Romero. We are both well versed in hormone replacement therapy and GLP-1 therapy. But really, the goal is to optimize all of our clients' health. And so, the way that we choose to do that is by addressing everything comprehensively. Here, we don't just dispense medication. We like to look at the entire client to know what's going on. in order for us to address everything comprehensively. And yes, there is a link. If you wanted to do a one-on-one consultation, if you're a provider and you want to connect with me, one-on-one consultation, it's a 15-minute power session, but that's where we can kind of connect and figure out like, what are your needs? What can I do for you? How can we collaborate? Thank you everyone for joining our second Fireside Chat. I look forward to seeing you again. And the next one, I believe we will be discussing either progesterone or vitamin D and how they fit into weight management. Both of those are also a supercharger for weight loss. So that will be coming up probably after the new year, but we hope to see you soon. Thank you so much for your time and have a good rest of your day.